Assalamualaikum warahmatullahi wabarakatuh and good day everyone. My name is Aina Najwa binti Nazri and I am postgraduate student from University Malaysia Pahang. In this video I would like to present my Citrex title, which is Simulation of Decompressive Craniectomy for Ischemic Stroke Treatment using a Computational Study. Ischemic stroke, one of the leading causes of death and disability worldwide. A prolonged ischemic period may cause brain swelling due to breakdown of blood-brain barrier. So patients with brain swelling due to ischemic stroke may suffer from the intracranial pressure. In order to reduce the intracranial pressure level in the brain, most of surgeons will performing a decompressive craniectomy surgery. A decompressive craniectomy is a procedure that involves a significant portion of the skull to be removed surgically. So this procedure allows the swollen tissue to bulge outwards from the skull, and it is usually treated as the last care management in stroke treatment. However, most neurosurgeons face some difficulties in making decisions before the surgery. It is either they need to perform a pre-operation of decompressive craniectomy before the brain swelling become more severe, or they have to perform an operation after the brain swelling becomes severe. Thus, in this research study, we aim to develop a conceptual model to investigate the effect of decompressive craniectomy operation on brain tissue swelling after ischemic stroke. So, the mathematical model used is based on poroelastic theory and capillary filtration. There are two different ischemic infarct sizes are used and simulated with and without decompressive craniectomy operation in order to evaluate the effectiveness of decompressive craniectomy in treating brain tissue swelling after ischemia reperfusion. So this modeling concept is actually used to provide some insights on using decompressive craniectomy for ischemic stroke treatment, as well as an additional information to the neurosurgeons. There are two types of brain geometry model, which are with decompressive craniectomy and without decompressive craniectomy operation. So as we mentioned before, there are two size of infarct that used to simulate, which is 40 millimeter and also 21 millimeter. So both decompressive craniectomy and without decompressive craniectomy operation has same dimension of the skull as well as the ventricle. So for the skull radius is said to be 80 millimeter, and while ventricle radius is 24 millimeter. Only the difference is the brain geometry. With the decompressive craniectomy has an opening skull with radius of 25 millimeter, while without decompressive craniectomy, skull opening is not included. Brain tissue swelling after ischemic stroke treatment has been modeled using capillary filtration and poroelastic theory. So the brain tissue swelling is based on these two equations. For the first one is the equation that relate between brain tissue stress and intracranial pressure, where is sigma ij is equals to total of tissue stress. PW is the interstitial water pressure. AW is water bioperimeter. While the second equation is for the distribution of interstitial water pressure, where QW is the relative water compressibility, KW water permeability, T is times, and SBW is the water transfer from capillary space into capillary interstitial space due to capillary filtration. So here we assume that after ischemic stroke, the blood-brain barrier breakdowns and causing the ions and small proteins to pass through it and accumulate in the brain tissue extracellular space. This accumulation causes the water from reperfused blood to go into the brain tissue extracellular space and leading to tissue swelling. In order to simulate brain tissue swelling without decompressive craniotomy, the skull geometry is removed and the skull is represented by using rigid wall boundary conditions, while the brain tissue swelling with decompressive craniotomy, the skull geometry is given material properties represented by Young modulus and Poisson's ratio. So both decompressive craniotomy and without decompressive craniotomy, the mass effect is applied to the infarct, while the ventricle is allowed to freely move. This is to enable the evaluation of herniation after brain tissue swelling. So for the decompressive craniotomy simulation, the skull is said to have its own material properties, while the skull without the decompressive craniotomy is said to be fixed. For initial condition, the fixed interstitial pressure is set at the baseline of intracranial pressure and also 0. Midline, or known as herniation, that happen here is indicate as severity of intracranial swelling in stroke. So based on this figure, the herniation that happen in both infarct with decompressive craniotomy operation is experienced lesser compared to the infarct without decompressive craniotomy. This might be because of the decompressive craniotomy operation that allowed the infarct to swell towards the opening skull has reduced the level of intracranial pressure, as the ventricular compression also reduced. However, there are some limitations that need to be considered. So even though that decompressive craniotomy has reduced the level of intracranial pressure in the brain, it might also contribute some complications after the surgery, such as stress that occur in between of the opening and brain tissue. So as we can see in the figure here, the biggest infarct, which is 21 millimeter, has higher stress around the contact area, and this phenomenon may cause tissue injury around the area. So based on the graph of the maximum pressure against time, it shows that after decompressive operation, level of intracranial pressure for both infarct getting lesser compared to the both infarct without decompressive craniotomy operation. It also shown that the pressure produced by the infarct with decompressive craniotomy reach steady state faster, while without decompressive craniotomy, it takes several times to reach it. So for the novelty, in this research, it provides a new-based learning for neurosurgeon before performing decompressive craniotomy surgery. So as the development of the computational study, the simulation is beneficial before surgery, as it may reduce the amount of error during surgery. And the simulation also is very useful as the additional information in order to guide the neurosurgeons. And besides, the simulation also may save the operation timing, as the surgery might run smoothly as predicted. Hence, it enhances the outcome of surgery. So the simulation is very useful for neurosurgeon as the guideline before performing decompressive craniotomy surgery, and it also has a potential user to be used in hospital, which which provide treatment for brain swelling. As conclusion, our computational study is useful as an additional information in clinical practice before performing decompressive craniotomy. And for the future work, we will be using a medical imaging data of a patient undergoing decompressive craniotomy for validation improvement purpose. Thank you.